All right. Well, hello, everyone. Thank you for joining us tonight as we host our pain management panel. With us, we have Dr. Bradley Wargo and Dr. Jennifer James. Before we begin, I'm going to kind of explain tonight's format. We're going to be doing everything question and answer style. So we've already had a few questions emailed to us, and I'm going to begin with those to give everyone time to submit their questions via the Zoom chat feature, and I will read them off to Dr. Wargo and to Dr. James for them to answer and respond. Tonight's webinar is brought to you by Crosstown Back Pain Institute and OrthoSouth. OrthoSouth offers comprehensive orthopedic care across 7 clinic locations in the Mid-South region, and we have 2 surgery centers in Germantown, Tennessee and South Haven, Mississippi. And Crosstown Back Pain is the only multidisciplinary pain management center in the Memphis metro area. To briefly introduce our panelists, Dr. Jennifer James is a chiropractor seeing patients at OrthoSouth's Crosstown Back Pain Clinic in Memphis, where she works and collaborates with other members of the multidisciplinary pain management team. She is certified in Cox flexion distraction technique and skilled in a range of manipulative techniques, including Thompson drop table, activator, diversified, and myofascial release. Dr. Bradley Wargo also sees patients at OrthoSouth's Crosstown Back Pain Institute, and he holds board certifications in pain management, interventional pain management, regenerative medicine, and anesthesiology. He's the past chair of the American Osteopathic Board of Anesthesiology and has participated on the editorial boards of the Pain Physician Journal and Interventional Pain Management Reports Journal. All right, panelists, if you're ready, we'll get started with the questions. All right, our first question. Let's see. All right. When would I need to see a pain management doctor?
I assume that question is addressed to me. So typically speaking, when somebody has pain that is not being relieved by conservative measures, usually administered by their primary care provider, that goes beyond 3 months, that typically is when the pain falls under the chronic pain, and that's when it's important to see a pain management specialist.
All right, and what can I expect when I see a pain management doctor?
Typically, when you see a pain management provider for the first time, you'll undergo a comprehensive physical exam and history. Depending on what area of the body is being evaluated, there may be x-rays taken of that area. And then based on the history and physical exam findings, and any radiographic findings that are appropriate, we'll come up with a diagnosis and a treatment plan to address those issues.
Okay. And now, what all does Crosstown Back Pain treat?
Well, here at Crosstown, we pretty much treat pain from stem to stern, from headaches all the way down to foot pain. And as the only multidisciplinary pain management clinic in the whole Memphis area. Again, I'm a board certified anesthesiologist and pain management physician, but we also have Dr. James, who's a chiropractor. We have Sam Shrelicki, who's an orthopedic spine surgeon. And we also have 2 doctorate level physical therapists. And so we have a full range of providers here to provide service.
And does someone have to be referred by a physician to be seen at Crosstown?
Typically, that's dictated by the patient's insurance. Some insurances do not require referral. Other insurances do, and so that would indicate whether or not they have to have a referral. It's always best, of course, if you're setting up an appointment to see any specialist or subspecialist that medical records are obtained ahead of time, if possible, just because that expedites the evaluation and treatment.
All right. Here's one question that was just submitted. If MRIs, etc., and doctors cannot locate the pain center, what does pain management do? And she also understands that there's 2 different types of doctors for pain management.
I'm not exactly sure I understand the question. Can you say it again?
Okay, let me rephrase. So I'm assuming she's talking about pain management doctor and an interventional pain specialist. Kind of what's the difference? And if her doctor can't locate the pain center, and if they're not seeing anything on the MRIs necessarily, what can a pain management doctor do for her?
Oh, I think I understand now. So I'm assuming the question is saying that either the MRI cannot be obtained or the MRI doesn't show something going on that they think the pain is coming from. Is that what we're discussing?
I read the whole question to you. I don't have any additional details. If
Sure.
you ever ask that question, would like to submit more details, I can read it off.
Yeah, I guess the difference I think I also heard in there between a pain management doctor and an interventional pain doctor. And an interventional pain doctor, practices the full spectrum of pain management, which includes not just diagnosis and treating pain, which may include um, uh, prescribing home-based exercise modalities, improvements in posture and body mechanics, medications when appropriate, but also doing injection therapy and minimally invasive surgeries to address pain.
Thank you, Dr. Wargo. We've got another question. This one's a long one. September 2018, I had an L5-S1 fusion with an artificial disc installed at L4. I recovered well, but recently pulled my performance playing golf. I can walk, stand, but cannot sit more than 5 minutes at a time. I've had steroids, anti-inflammatory drugs, and last week an injection done. No relief yet. I've also seen a physical therapist with some relief. I sit a lot at my job and need this fixed. What should I do?
So again, without seeing the full details, the piriformis is a muscle that attaches from the side of the sacrum across the buttocks to the greater trochanter, which is a little bony bump on the side of the femur bone. And if that muscle spasms intensely, sometimes it can mimic a disc herniation in the back because it can aggravate the sciatic nerve. But if this pain is specifically located in the buttocks, and if that injection was just a muscle injection and not targeted specifically to the piriformis muscle, then you may not get the benefit you're looking for. The issue is if the diagnosis is confident that it is coming from the piriformis muscle and the patient doesn't get benefit specifically from an injection into that muscle or doesn't get long-term benefit, then the patient can be sent for Botox injections to the piriformis muscle.
Thank you, Dr. Wargo. All right. I have back pain due to osteoporosis and scoliosis from the osteoporosis. Do you have any recommendations for ways to manage the pain other than medication?
Certainly there's a realm for Dr. James in this respect to help with biomechanics and myofascial techniques. Scoliosis is a typically degenerative phenomenon, and arthritis is one of the big results of that. Besides core strengthening exercises to help support the spine to slow down the progress, there are injections we can do to diagnose specifically which joints are involved in producing the patient's pain. And if that patient derives benefit from those injections, then we can actually do an ablation procedure where we can put those nerves to sleep long term. Unfortunately, that's not curative, but there's also unfortunately no cure for degenerative scoliosis. And so we do look at ways to help manage it as best we can.
All right, thank you. Now, what will a chiropractor do for my pain?
So chiropractic care is a conservative option for patients if they'd like to try something like this for different reasons. Maybe they're not a surgical candidate, or they'd like to try something conservative first before moving on to something a little bit more aggressive. We will do all patients are on a clinical trial basis. And so we will do gentle manipulation or techniques that could help reduce tension in the stress in the disc to make sure that the joints are moving correctly and placed in the most optimal place. And so if things are as optimal as they can be as far as movement and position, then tends to let the body correct itself and see if that doesn't help the problem. Usually I'm educating patients too on what not to do or what they're doing that's continuing the pain cycle. So education is a big part of it.
Thank you, Dr. James. Now, how do I determine whether a physical therapist, chiropractor, or a physician is better for my first visit?
Typically, a physical therapist is not the first person that you go to. Typically, it'd be either your primary care provider who does an initial assessment. But depending on what the mechanism of injury or the type of pain that you have would really dictate where you go. And again, either a pain management physician or your primary care doctor can help steer in the right direction. But as long as you're not having what are considered red flag symptoms like loss of control of bowel or bladder function or weakness, specifically in your arm or your legs, I would certainly try conservative measures first, and Dr. James can certainly do full assessments of patients.
What is the difference between acute and chronic pain?
So by definition, acute pain is new pain that is of less than 3 months duration. Once you get to 3 months, it's typically classified as chronic pain.
If I have chronic pain, is there any hope for a cure, or am I stuck with this for the rest of my life?
In pain management as a specialty, we're primarily looking at management, always hoping for cure, but that doesn't necessarily mean that just because you have chronic pain that you're going to always have pain. It could just be that the source of the pain has not actually been determined, and proper diagnosis to treat that specifically may get you a much better outcome.
I would like to add to, often people that have chronic issues are not addressing some of the behaviors and positions and activities that they're doing regularly that can be regularly irritating those chronic issues. And so a lot of times we assess for what they're doing and change some basic things and how they sit, how they stand, how they work, and that we can minimize or help them to control and minimize that pain so that it doesn't continue to be ongoing an issue.
Do you refer to mental health or therapy as a part of pain management protocol?
Absolutely. When medically necessary and appropriate, we do routinely.
All right, thank you. What are some safe topical medications that might help arthritis pain?
So over-the-counter medications, there's certainly lots of balms and creams that can be used. There are over-the-counter versions of lidocaine, whether that's in ointments or patches. There are also over-the-counter versions of non-steroidal anti-inflammatories like diclofenac. But then there's also prescription topical medications that have combination of prescription medications that can be applied to folks of pain that can have medications like muscle relaxants, nerve pain medications, and local anesthetics. There's lots of options.
Thank you. Now, okay, what are the most common problems that cause chronic pain?
In the United States, it's typically neck and back pain. Dr. James?
Well, I was just going to say so many things can cause chronic pain, normal degeneration, wear and tear, overuse, repetitive motion, joint degeneration from injury or from overuse again. So lots of things that are the source of it. And once those degeneration processes happen, there's not always a curative issue. We can always cure it, but we can definitely help to control it or help it to slow down the process of degeneration.
What are the most common medications used to manage pain?
So typically the most common classes of medication that are used to treat pain are non-steroidal anti-inflammatories if a patient is a candidate. There are 3 different classes of medicines used to treat nerve pain specifically, and those are tricyclic antidepressants at low doses help with nerve pain. There's a class of medicine called gabapentinoids, and there's 9 different medicines in that family. Then there's also newer classes of medicine that are commonly used to treat diagnoses like depression and anxiety, but at certain doses have also been found to help treat nerve and muscle pain. And then in certain circumstances, opioid analgesics can be used to treat chronic pain.
All right.
But there's also local anesthetics and muscle relaxants.
All right. Thank you very much. Now, I've heard that I should avoid back surgery at all costs. Has it gotten better over time? Is it worth pursuing for some people? And what are the circumstances?
So again, indications for back surgery primarily are pain that is unrelieved by other measures or red flag symptoms like we discussed earlier. Surgery should always be a last resort just because surgery itself is not curative. It's just aggressively managing the problem. And so with surgery, there's always the risks of the surgery itself, but there's also the concern that sometimes even with successful surgery, if the problem is degenerative, even with surgery, the degeneration continues, and it is certainly possible that pain can come back, but the hope is that it's years and years later. But certainly surgery is indicated at times, and if you can avoid it, you should avoid it. If you need it, though, you need it.
Thank you, Dr. Wargo. Now, what is injection therapy and what types do you offer?
So injection therapy is using targeted needle placement to joints, muscles, nerves, tendons. We do those here at Crosstown at our surgical suite. And these are typically either done under ultrasound guidance or fluoroscopy, which is X-ray guidance, to specifically target to just not only treat pain, but also to diagnose and hopefully manage the pain to give as long a relief as possible.
How long should I expect my injections to last?
So if the injection is purely diagnostic, which is required in certain circumstances, that would mean the injection just has local anesthetic in it, which can be expected to last hours to days, depending which local anesthetic is used. And there's many circumstances when diagnostic injections are important because that helps us gauge further treatment. If steroids are used in the injection for therapeutic purposes, then we would anticipate those lasting weeks to hopefully months.
Thank you, Dr. Wargo. Now, Dr. James, this one is directed towards you. I read online that you also treat patients in life skills like weight management and nutritional direction. Would you be able to tell me anything about that?
That is really a case-by-case issue for patient to patient, but I always counsel patients if they have to manage some of their degeneration, knees or hips or spine, if they have to lose weight, because that's going to accelerate, again, the degeneration. What I talked about earlier is, as far as life management skills, what is their job like? Are they sitting? Are they standing? What kind of repetitive motions are they doing? We always discuss that in our treatment protocol and how we're going to help manage their individual case. So there's lots of weight management programs out there. I recommend some for some patients and others for others. It's not always aggressive. Sometimes it's not weight, but sometimes it's just how they're doing what they're doing every day. So it's really case by case, patient by patient, but I always do counsel in all those areas.
Thank you, Dr. James. Now, someone asked if we would go back over what a multidisciplinary practice is.
Sure. And so multidisciplinary means you have more than one discipline of medicine or practice. And here at Crosstown, have physician anesthesiology pain doctor. We have several physician assistants that assist me. We have Dr. James, who's a chiropractor. We have Samuel Shrelicki, who's an orthopedic spine surgeon. And then we have 2 doctorate level physical therapists. And so essentially in the field of pain management, the only specialty that we do not have in-house is pain psychology.
Thank you for explaining that again. Now, this person asked, will you keep my primary care doctor informed and up to date?
It is always my standard of practice to, every time a physician sends a patient to me, that they get a referral letter back from me discussing our treatment plan. And then every time I see the patient back, we send them a copy of that visit also.
All right. And we have another question kind of about physical therapy. What exactly will a physical therapist do for my pain?
Dr. James, you want to hit that one? You would like me to?
Go ahead. Do you want to field it or you want me to field it?
It's up to you.
Yeah, our physical therapist will do a full evaluation and find muscles that are either weak or overstimulated. They'll also find inadequacies in certain muscles, and regardless of the source of those inadequacies, sometimes it's neurologic and sometimes it's use or damage. They will still find lots of creative ways to try to get those muscles to come back to active and working. They'll balance out these imbalances. And so with that regular training and one-on-one training, they help to bring back pelvic stability, muscles that are weak, any joints. They do a lot of rehab of post-surgical knee replacements and hip replacements. And so get those things core balanced and strong again so that you can, do optimal movements. So they're there to help stabilize muscle tone, pelvic stability. Dr. Wargo helps with all the nerve control and pain medication, and I help to work on joint placement, joint movement.
Thank you, Dr. James. I'd like to take a second and invite our attendees to submit some questions. But we just had one submitted about pain medication. They would like to know if all pain medications are addictive.
No, not all pain medications. Primarily opioids are the addictive class of medication. If somebody has a true source of pain, the statistical likelihood of them becoming addicted to pain management or pain medication has been shown to be less than 2%. It's those who don't have an active source of pain or who are taking pain medications for inappropriate reasons, escape or whatever it is, that are obviously more likely to become addicted to them. But as a class of medication, opioid analgesics have that potential risk.
All right. Thank you, Dr. Wargo. Now, in instances where narcotics would normally be prescribed, are there any alternatives for someone who doesn't want to take narcotic medication?
Absolutely, and that's the whole reason why we have a multidisciplinary pain treatment team here, so that we have other avenues and modalities to help manage pain besides opioid analgesics or narcotics. Narcotics is actually a term pretty much used by law enforcement and medicine. They're called opioids. Just for background, an opiate is derived from morphine, whereas an opioid is a synthetic narcotic or synthetic narcotic type pain medication. But there, as discussed earlier, there are lots of other classes of medication that we use every single day besides opioid analgesics to treat pain that are very successful.
Thank you, Dr. Wargo. Do you do dry needling at Crosstown?
Our physical therapists both do dry needling.
Okay, and now we have another question about injections. What type of injections are available to help with pain from arthritis in the knee or painful total knees?
Okay, so if somebody has pain in the knee itself and they've not had surgery, there's a typical algorithm of management that we go through, or course of typical or standard care. And that is obviously once we identify that the knee is a source of the pain. If it's a degenerative phenomenon like arthritis, typically, besides physical therapy, weight management, home exercise modalities, typically then we use non-steroidal anti-inflammatories if a patient is a candidate for that class of medicine. We can do steroid injections into the knee, which do decrease the pain and help improve mobility, to help with standing and walking. If those are effective, those can be repeated every once in a while, but you should certainly limit the amount of steroid exposure a patient has in a 12-month period. If the steroid shots help but don't last a long time, then the next course of action is usually a viscosupplement type of injection. And there are 6 different companies that make those, and that's which one we use is typically dictated by the patient's insurance. But that's an injection of a gel type compound that goes into the joint, which kind of lubricates the joint and provides more cushion to help with standing and walking and motion. If those things fail, or if the patient has had surgery but still has pain after knee surgery, we can actually do a procedure called a genicular nerve block, where we block the feeling nerves, not the motor or movement nerves, but the feeling nerves that go to the joint. And if those diagnostic blocks are effective, we can actually do an ablation of the nerves that go to that joint. And if that works like it's intended, textbooks say those can last anywhere from 6 to 12 months. Longest I've ever had one of those last on one of my patients is 3 years. But that is not up to me. That's up to the patient, because the patient will regenerate those nerves over time.
Thank you, Dr. Wargo. Is peripheral neuropathy reversible?
Currently today, we don't have the technology to reverse neuropathy, because neuropathy implies essentially permanent nerve damage from whatever that source, whether it's in the United States, very commonly diabetes is a common cause of that. But there's also what's called idiopathic neuropathy, which means that we don't have a focal source of what causes the neuropathy. But other common things in the United States are vitamin deficiencies. It can lead to neuropathies. But there are medications that are very effective to treat neuropathic pain. And if those things fail, there are other modalities we have to treat neuropathic pain.
All right, thank you. Next question or kind of story, but I had a block done about 3 months ago and it works. And I don't have any pain, but I still have a great deal of pressure in my lower back and I cannot stand up straight for very long. What can be done now?
That's kind of hard to answer without further information about this specific patient, what type of block they had, and what type of pain was being treated. So I'm kind of limited on that one. I apologize.
Okay, we'll move on to the next question then. Does orthobiologic medicine have a place in pain management?
Absolutely. I was actually the first board certified physician in the state of Tennessee in regenerative medicine. And that's what the branch with orthobiologics is. And there's whole different class of techniques that we have to treat patients, and that's in regenerative medicine. The whole goal of that is to help restore function and improve outcomes to reduce pain. And there's lots of different techniques that we have for that.
Alrighty, now I believe this is one of our last questions, so if you have one, please submit it now. But do you have a block that would help prevent shingles or help with shingles?
To help prevent shingles, there's a varicella zoster vaccine that they can get from their primary care provider to help minimize the risk of getting shingles later in life. If the patient actually has shingles and it's active and they still have the weeping rash, then there are topical medications we use to try to minimize that pain, plus nerve pain medicine that we help to use to treat that pain. Once the rash starts to crust over, then the patient is actually no longer shedding the virus, because if a patient has active shingles and has the weeping rash, they're actually shedding the herpes virus just like when they had chickenpox as a kid. And so obviously we want to keep them away from other people until that crust over, so that you don't potentially infect somebody that hasn't already had exposure to that virus. But once those lesions have started to crust over, we actually can target the nerve to try to suppress that nerve pain and put that nerve back into dormancy.
All right, Dr. James, we have another question for you. Do you have any guidance on whether a pregnant person should receive chiropractic manipulation?
I think surely if you're having symptoms during your pregnancy, which most women do have some lower back pain or pelvic pain, especially near the end of their pregnancy, it's always prudent to go and have that pelvis checked out just to make sure everything is aligned correctly and moving correctly. As you get further into pregnancy, those joints start to loosen and open up a little bit in preparation for delivery. And so if something is a little bit off kilter or a little wonky, you want to make sure that that's as straight and normal as it can be, so that when delivery approaches, there's no complications of delivery as far as how the baby can come out based on where the pelvic bones are lying. So it's a good thing to check out, especially if you're having excessive pain or ongoing pain in one side or the other during the middle or late stages of pregnancy.
All right, thank you, Dr. James. What are some techniques you could use to manage fibromyalgia pain?
So fibromyalgia is a neuromuscular disease that unfortunately no X-ray, CAT scan, or MRI can diagnose. But there are other modalities we use to make sure that we're not missing something else when we're making a diagnosis of fibromyalgia. But there are several classes of medicine that can be used to treat that. The keys, though, to proper management of fibromyalgia is getting good sleep hygiene, good diet, and good exercise.
All righty, next question. Is there a relationship between peripheral neuropathy and vascular issues?
There certainly can be. And so when somebody is being evaluated for like burning or electric type pain in their legs, nerve and vascular studies are typically done to make sure we know which we're treating. But again, in the United States, diabetes is one of the most common causes of peripheral neuropathy, and that is caused by loss of the small blood flow to the lower extremities, which damages the nerves in that area also.
All righty, well, I believe we've kind of gone through all of our questions. Dr. Wargo, Dr. James, would either of you like to say anything before we conclude this webinar?
I would just like to say I appreciate everybody's time and the willingness to come talk to us and allowing us to help them as much as we can.
I agree. I think that sometimes people have a different understanding of what a pain management clinic is. Often I have been approached with people saying they think this is just somewhere that gives out opiates or drugs. And that's not what we are at all. We're definitely here to help people minimize some of those medications if possible and optimize their life and their function in as many ways conservatively as we can. And if something does need a more aggressive treatment, we're there to help direct them through that.
All right. Well, thank you, Dr. James. Thank you, Dr. Wargo. I know I've learned a lot through this webinar, and I hope everyone else has too. This webinar was recorded, and very soon it will be up on the OrthoSouth YouTube and OrthoSouth website if you would like to reference back. Thank you, everyone. Thank you, panelists, and y'all have a good night.
Thank you, everyone.
Thank you.